First, I want to say we might be setting a record today. I believe we have 200 people registered for attend, not only you in the room, but like 150 people from across the country online. So this is a hybrid event. So I'm so grateful for those of you that have shown up here today, but then also those of you who are hybrid and you're signing on from online. I think it really helps spread some of the work that we do here, and we want to share some of the things we're learning with the rest of the field. And especially kind of innovations. So please spread the word. If you find this useful, spread the word about other Levitt lectures. Then you can add yourself to our notification list. I also want to take a moment to recognize that today is Juneteenth, which is a day that we recognize where enslaved people in Texas finally heard that the Civil War was over and they were now free. So it's a very important day. It's a holiday in some states, and those of you that are choosing to be here today or sign on, thank you. We really appreciate that. A little bit about the history behind the Levitt Lecture. Dr. Lewis P. Levitt was born in Denver in 1896 and graduated from CU School of Medicine in 1927. He practiced medicine in Denver until 1967. He's a family doc. And as one of his ways to contribute to the field, he gifted an endowed lectureship to the department in 1978. And that allows us to bring in speakers, to host these kinds of events. And philanthropy is a foundational piece of continuing the good work that we do. So we're very grateful for that. The purpose of the Levitt Lecture is to bring distinguished speakers from various aspects of healthcare that are important to primary care, and particularly if it has relevance to what we're doing here at CU. And it's because we and Dr. Levitt believed it was important to stay educated and current on what was going on and what were the current but also emerging trends in primary care that will affect our practice. I want to remind you there's QR codes on your desk or your table to, we really take seriously your feedback about these lectures so we can improve them. And as listed, the event's being recorded in case you miss anything. So now I want to welcome our speaker, Mr. Tony Rodgers, for his talk, Characteristics of Succession Failure Under Value-Based Alternative Payment. A little bit about him first. Over his 40-plus years in healthcare, he's held executive positions in just about every leadership seat you can sit in without being a physician, both in the public and private sectors. His executive leadership experience included positions with CMS, state Medicaid, health plans, and hospital systems. He's previously deputy director for CMS Center for Strategic Planning, oversaw the CMMI innovation projects at states. He was a principal then with Health Management Associations, where he continued his work with healthcare professionals and systems at all levels. And he's currently the Chief Executive Officer of VB Care Network, LLC, the startup healthcare in Arizona, provider-led network. He has a Master's of Science in Public Health degree and a BA degree in Economics and Political Science from UCLA. We used to text smack to each other when U of A was playing UCLA. In basketball. He's held visiting professor appointments at Arizona State University, W.P. Carey School of Business, and at UCLA School of Public Health. And now a little personal anecdote. I first met Tony when he was director of Arizona State Medicaid Agency. And honestly, at that time, I kind of viewed him with some suspicion and animosity as the embodiment of how most providers felt towards our state Medicaid agency as a payer. But then I soon learned, much to my surprise, that we share a passion and a belief in primary care to improve the health of patients, families, and communities. And also, a bit surprisingly, I learned later, I also learned that we shared an interest and a belief in the power of increasing patient activation and healthcare literacy or health literacy to improve the lives of Medicaid patients, and also the power of innovation and research to improve their lives, and for the patients that are so often at the very end of line to receive the benefits of innovations in healthcare. So that has kept us in contact all these years. And with that, I'm pleased to welcome Mr. Tony Rodgers.
Okay, well, thank you very much. And thank you for the opportunity to come here and let me grab my clicker and talk to you about value-based payment. It's an area that I've had some policy experience with and management experience with, and it's an area that is still, I would say, in its relatively infancy. That's beginning to grow and develop across the United States. But what I'm seeing and what we'll talk about is the direction that value-based payment goes will have a lot to do with how the state handles the value-based payment efforts within their state. So I wanted to cover the understanding of value-based payment, just to give everybody level set, identify some key factors in value-based success, how to avoid the pitfalls, and then federal and state policy implications. So that's what my lecture is going to cover. I'm going to first start out by talking about where it all started. So Redefining Healthcare was a book that came out in 2006, and had a chance to read it. It was given to me by somebody, and in which they basically argued that we have to move away from fee-for-service to value, which struck me as, oh yeah, that's right, we should do that. How we do that is going to be the question. The people who, when I was at CMS, had the greatest influence on me, because I came to CMS just before the ACA was passed, the Patient Protection and Affordable Health Care Act, were Don Berwick and Mark McClellan. And I had the distinct pleasure of working with Don and working under him, and to hear his passion about system structuring and the importance of payment reform. And then Mark McClellan was somebody who I was so impressed with in terms of his vision. And so with Don, he famously said before Congress, and this is why he only was CMS administrator for 18 months, is that I guess it's politically correct to widely believe that, to say that the American healthcare system is the best in the world. It's not. And I think that upset some of the members of Congress. But internally, Don would quote Deming a lot and said, basically every system is perfectly designed to get the results it gets. And I agree with that. And so what we're trying to do is redesign the system to get new results. And that's where value-based payment comes in. Now, Mark has done a lot of research, and he works at Duke. He's put out a lot of articles, co-written a lot of articles since this one, but it struck me that to overcome the current system, and this was his view of the perverse incentives and fragmentation caused by fee-for-service, we need to become accountable for overall quality and cost of care for the populations we serve. This accountability for overall cost, quality, and provider incomes can begin to be decoupled from volume-based care to and intensive services. So his strong belief was that somehow if we could decouple providers from the tyranny of fee-for-service, that we could change the system and create an overall accountability for quality and cost. As I mentioned, the ACA was probably the seminal act that was passed that really has allowed us to drive value-based payment. Specifically, two provisions, Section 2021, which established the Innovation Center, which I was involved with, as well as Section 30/2022, which established Medicare shared savings. And you have to appreciate Medicare being a national coverage for seniors is a major driver behind value-based payment. And the reason was that if you recall back in, 2010, 2011, the biggest issue was the sustainable growth schedule, which basically started cutting providers' rates at the Medicare level. And so the alternative was to move to value-based. So this was a way to stimulate the interest by providers to move to value-based payment. CMS's rationale, of course, was to reward healthcare providers with financial incentives or penalties for the quality of care that they give to the Medicare beneficiaries and the reduction of costs that would accrue to Medicare. So in a way to save Medicare financially, they had to dampen the inflationary factors in Medicare. And by putting physicians at risk, or the providers at risk, they felt that this would help dampen that growth, because providers would then realign themselves to take better care of the patients, better care for individuals, better care for populations, lower costs. That was the mantra. But shifting accountability is the problem. Moving accountability to primary care providers is, in theory, the way that we should go. But in application, that's where we see a lot of variance throughout the United States. The core of value-based payment is the belief that you can reduce the demand for healthcare services by better managing the care at the point where you can intervene to avoid an acute care episode. And to do that, you have to hold a provider accountable, and that's where primary care providers were the logical choice to be the ones who would intervene in the patient's acute care episode and avoid those acute care costs. The drive to move to value-based on CMS's part was an approach that will assume, because it is an assumption, that you'll make more money if you reduce unnecessary costs and avoidable costs, but it makes the assumption you know where that avoidable cost or unnecessary cost is, and that you can then manage the patient so that you don't have those costs. That has been a challenge for many providers, and we'll talk about that. But it also created the opportunity for an umbrella organization to form called the Accountable Care Organization, which would receive dollars through CMS, and by doing that, spread the risk across a broader population of patients, as well as network or contract with specialty networks and enter into stimulate the interest in bundle payments. So, accountable care organizations, of which I'm running one, there's no single or precise definition of what they are. And indeed, it's whatever flavor you think. They can be large, they can be small. They can have significant infrastructure or not. I will say the difference between an integrated ACO and a non-integrated ACO, where you're just dealing with primary care providers, is significant in terms of the dollars that are available. But also, the fact that they've grown so fast. This was one of the issues I had with Don. I asked him the question as we were developing the policies related to the ACO. Based on the policy direction we were going, I felt that there would be a number of ACOs that would form but not be successful, lose money, and then those providers would be injured by the fact that ACO wasn't stable. And you have to appreciate the fact that, well, that wasn't well received, for one. But number two, CMS works as looking at it from the Beltway's point of view. And back there, providers are organized. They have a lot of capital. Out here in the Wild West, I said, it's not so much the case, and that what we really needed the ACOs to do is be flexible enough and to have resources that would have to come from someplace. And that's where, to some degree, we got the dollars that CMS provides as a loan to ACOs in advance of them achieving savings. The problem is you have to pay the money back. And so you end up spending the money, and if you don't save the dollars, now you owe CMS dollars back. But the concept is the right concept: to spread risk, to contract with preferred specialists and organize them with the primary care provider so that the primary care provider can be better integrated as an integrated team with their specialists, create economies of scale on IT, do the claims payment and claims reporting, and then care management and care coordination. Those are the key elements, I think, that the ACO brings to the table. And these are all necessary, I think, to achieve the financial incentives at CMS, as well as other organizations that are contracting with providers for value-based have set up as targets. So as you know, value is typically formulated as a set of outcomes that is determined usually by the payer for a population of patients that they're responsible for, payers responsible for, that are assigned to practices in some methodology, and that the total cost of care, the delivery of those outcomes, is specified in a performance period, whether it's a year, whether it's 6 months, 3 months. You have a particular performance period that you have to achieve those results. Now, in fee-for-service, that's not true. There is no technically performance period. And so in this model, now you have the, if you will, the issue of time. How much time do you have to achieve the results that you've been assigned to achieve? And so that's where it's oftentimes difficult for providers to be successful because they can't achieve the results in the time frame of 1 year or 6 months or whatever period the payers have set up. I provide this slide just to break down the components of most value-based payment arrangements. So there's an assigned or attributed population of patients. Now, the reason they're assigned or attributed, as those in the industry probably know, is because there's no enrollment process to your provider. You don't go and say, I want to enroll with this particular provider. You're assigned by the payer based on some methodology they've come up with. And sometimes the methodologies are equitable and sometimes they're not. The payer, or at least in the public side, also gives you guidelines on what you can communicate to the patient about the model or about the participation of the providers. Medicare is particularly restrictive in what you can say. And then also the assigned population that's given to the participating provider, the assumption is they have some relationship previously with that provider. And that's, in some cases, not always true. I know in Arizona, my network is assigned members who my providers have never seen. And so the issue, when you have that incorporated in your methodology, is that now you have to engage patients who didn't choose you and don't understand why they're being called by a particular physician. The accountability at the PCP level is also a unique element of value-based payment. There are bundles, but the overall cost of care still remains, the focus is still at the primary care level, on the assumption that the primary care level patient or primary care practitioner has the greatest opportunity for early intervention and for avoiding acute care episodes. And then there's quality targets, of course, and those are set by the payer based on what they feel their priorities are related to patient quality. So the payer is defining what is the value proposition, and the provider is responsible for meeting that value proposition. If the provider doesn't, either they don't receive the incentive, or in the worst case, they can actually end up with a penalty. And then there's a total cost of care benchmark, and this is another area where programs, whether it's state or federal, whether they're commercial payers, are all over the place in terms of how they set the financial benchmarks, what goes into the financial benchmark, the level of risk adjustment, when the risk adjustment's done, the level of discounts the payer takes, the withholds that they take out of the system that have to be earned back, and any other adjustments that they make. And then finally, there's whatever the percentage is of savings or shared loss that the practice or the ACO would potentially bear or gain from if you met the requirements. Now, that's primarily in the risk-based alternative payment arrangements, but in terms of the overall value-based payment structure, that's all part of the component parts of it. So, one of the things I've noticed about state Medicaid, even when I was at CMS, is that state Medicaid offices are all over the place regarding their goals for the Medicaid program. Some see it as welfare, and they're just trying to keep it cut back and reduce it as wherever possible. Others see it as an important part of their population health strategy for the state. I think Colorado is in the latter, and I think that's great on your part because not all states are where you are. And so just like that, in terms of their policy goals, so too their value-based payment arrangements reflect oftentimes those policy goals, whether they're trying to take money out of the process early or whether they're trying to build a infrastructure that will get them value down the road. And then states also delegate in many cases, as the case of Arizona, to contracted health plans, and they are all over the place related to value-based payment. So let's talk about some of the state arrangements. If I were to say some of the areas that pop up the most often are, one, the stability of the enrolled population. The Medicaid population can be a very transient population. There are people who are homeless, who cost more to engage, if you will. They're not as stable. Medicaid beneficiaries move a lot within the performance period. And if you're holding a provider accountable for a performance period and you don't have a stable population, it really puts them at risk, uniquely at risk. And then the distribution of the population. Is it, as in the state of Arizona, most of our population's in Maricopa, and so that's where all the providers are. And you see different levels of performance than you see in the rural areas of Arizona, where reaching out to those beneficiaries is much more of a challenge. The distribution of the population and the types of practices we have. Many more specialists are located in Tucson and Phoenix, and I'm sure similar situation, urbanization of specialists has occurred here in Colorado as well, which then means that the beneficiary has to travel to see a specialist, et cetera. And it really affects the integration between many of the providers, especially in high need, low manpower shortage areas, and getting access to care. There's also a significant gap I've seen in programs across the United States in the performance requirements and aligning that with the capacity and capability of primary care network. It's almost like they jumped into it saying, oh, well, we're going to do this because everybody else is, not doing an assessment. Well, where are the primary care practices and their capabilities? And then perceived risk or compliance costs. By compliance costs, I mean the compliance costs of the provider. There's a cost to get all the things you have to get done in many of the state requirements and maintain them, the documentation, the submission of information, et cetera. And that's a cost to the practice. The question for the practice is what's the opportunity for positive return on investment? And when am I going to see that positive return on investment? My practices, which are FQHCs, are asking that question all the time. Is that, okay, if I do all this extra infrastructure, when am I going to see return on that investment? Because if I do that with this, for this money, I've got to get a return on investment or I'm taking it away from other programs I'm trying to do. including community outreach, etc. And then the other area I have found has affected state programs is whether there's significant distrust and animosity between the providers who serve the Medicaid beneficiaries and the state in the way that it's done, either fee-for-service or other activities that have created a discord where there's a lack of cooperation. Saw that a lot in California, where providers were not trusting that the state's move to value-based was anything more than a ploy to pull dollars out of the system. So that's where kind of the overall landscape, just so that you know, you're very fortunate here in Colorado because you're much better organized than many states in this area, and you have good focus. I mean, yes, everybody can do better, but I am impressed with what I've heard about what's going on here in Colorado. So I'm using the typical categories of value-based payment to articulate how each one affects providers and how each one affects primary care providers in particular. So you have the fee-for-service without quality, and that is mother's milk to a lot of providers. It's just the way they do business. They've set up all their systems around it. It works for them, and they don't want their, if you will, their environment affected. But moving beyond that, as we go into the initial levels of value-based, you have to move using fee-for-service as a base to quality performance. And that's the first level everybody seems to move to. Let's get paid for performance in place, hold providers accountable for some specific targets, and then give them incentive payments in some way. And then there's category 3, which is more the intermediate, which is shared savings and shared savings with downside risk, bundle payments, evidence-based payment procedures, where if you stay within the evidence-based protocol, you get the dollars, the average dollars. There's been the Comprehensive Primary Care Plus that CMS rolled out to build infrastructure in primary care. So all of these are kind of category 3 because there's a shared savings, shared, in some cases, shared risk associated with them. But then you go to category 4, and this is where you really have to have your act together. You have to have the resources and the capability. When you take global payment, or whether it's capitated for condition-specific payments for a high-risk population, or it's just global payment for a population of patients attributed to you. And when you're in category 4, you have to have extreme alignment between your primary care providers and the rest of the system, because you're relying on them to reduce your costs up front by early intervention, et cetera, changing the cost profile, if you will, of your population. So at the population health level, whether you're an ACO like ours, we're always looking at the population and segmenting them, stratifying them, looking for strategies where we can build competencies and core capabilities into our primary care network to address the longitudinal costs of these populations. So if you want to look at it from a maturity point of view, if you are in fee-for-service, there's no need to go beyond your own clinic or beyond your own group practice or integrated delivery system, because it's basically a transactional-based relationship that you have with the patient. So there's really no value-based maturity required. But as you move up to the initial pay for quality, you have to have at least some maturity and understanding of value-based payment and how to achieve quality performance on a population of patients that have been assigned to you. And that's the biggest difference. I would say that most providers, until we started with value-based, didn't know who their population, they knew their patients, they didn't know their population of patients. And so that's a very important part of maturing your providers, is begin to talk about the population of patients we're managing and the strategies we have to implement. And then the intermediate level, this is where you get into shared savings, shared risk. And it's really important to have the systems in place, the data analytics, the population analytics, the strategies have to have matured to a point where you're not just planning to implement, but you have implemented and executed on key strategies to manage the patient's care and control costs over time. And then on global payment, this is where it becomes one where you become, in essence, a insurer. You are ensuring that you can provide the care for the amount of global payment or benchmark or capitation that you are receiving, and you take the risk if you don't achieve the benchmark. You end up paying back Medicare or not receiving payment for any overage over capitation rate. So each of these categories have different participants. And in category 3 and 4, what we see typically are ACOs, integrated delivery systems. We also see provider networks like IPAs, especially in California and other places, networks that have had some relationship with their providers and see this as a possible way to bring more money into their provider network. But unfortunately, many providers who participate initially in value-based fail to launch. They don't get through that maturing process and get stuck either at the quality improvement level, even though the system wants them to move forward, they're not able or interested in doing so. And so failure to launch is a problem if you have providers in your network that you can't get to cooperate with the next level of maturity. So overcoming the failure to launch means overcoming the fee-for-service culture. It's the reality is fee-for-service has been around for 50 years. It's ingrained in everything the provider does, from how they make appointments to their internal processes to how they train their staff. It's all about that fee and proper documentation, et cetera. When you start to move away from that, you're talking about claims coding systems that have been set up along a payer line so that you're properly coding your claims to get the maximum amount of dollars. You're talking about provider billing processes, revenue maximization methods. So there's a whole industry that we're now trying to look at and say, well, we won't need those things as much anymore once we go to value-based. So when we think of fee-for-service culture, it's part of the psyche of the provider that has to be overcome because that's how they think of their real revenue, and that this can become a marginal revenue effort like, oh, I'll get a little bit more, but really it's my fee-for-service revenue that's most important to me. And if that's the case, then they don't spend the cognitive time that they need to thinking about their patients who are high risk and need earlier intervention. And they don't want to invest in whether it's care management, community health workers, people who can outreach for them, et cetera. So as I look at it, when I look at our market and tell me if this is similar up here, I see provider attitudes as how risk averse they are. And even if there's no downside risk, it's still a risk because you're asking them to do a lot of work that they have to add some stuff. Am I going to get a return on that work that I have to do on changing my systems, changing how I do things? And so we have in our market what I call the resistors. Oh, not us, not me, not now. I'm not ready for this. And if they represent a significant portion of your market, that's going to be a problem because you want your resistors to be 10 to 20% of your market of providers, not 30 to 40% of your market of providers, because you'll get a backlash from the resistors if you push too hard. Then there's a skeptical and passive. Oh, yeah, but, I was involved with something like this before and it didn't work out and I never got any money and blah, blah, blah. And they're skeptical about why they should move to value-based because of their previous experience, or they're just skeptical about the model, that it will achieve what it's supposed to achieve. And they tend to be passive about it, like, I'll see what happens. And they're hard to get to engage and become part of the model. And if this is a large portion of your population, you have to develop strategies to bring them to a level where they move from being passive to more active in wanting to participate. And that takes time, effort, and to some degree a credibility on the part of the state and others that this model will be the model of the future, and that we're not talking about the flavor of the day. And this is not going to be just a new initiative and it's going to go away as soon as payers go in a different direction. And then you have your champions. And so as you move along that line, you want your champions to be at least 10 to 20% of the population of providers you have, because they're the ones you're going to use to demonstrate to the others that this is a way of the future, and it actually provides better care to the patient. And so your champions are not only the ones that you lift up and you show to other providers this can be done, but they are also the ones you use to go out and help and mentor other providers as well. And so I have found that there's a tipping point with providers as to when they will take it seriously. And we had a discussion last night about where that tipping point is. I have found 35% at a minimum is where the provider's tipping point is, when they get 35% of their population in value-based, they start taking seriously the future direction of value-based and want to begin to prepare themselves to participate in shared savings or other models. They change from fighting you to wanting you to help them achieve and maximize their value-based payment. Now, you can argue, well, maybe it's not 35% of your market, maybe it's 40%. But between the 35 and 50% range, depending on the market, is where you need your providers to get to their tipping point. And if you have assigned members, whether it's Medicaid, commercial, whatever, that represents such a small portion of the provider's patient population, you will find that the provider is going to be less likely to want to put in the dollars to invest in something that they're only going to be focused on a small portion of their overall population. So getting more patients under value-based payment is really important to get provider buy-in. And this is also an issue where the provider's patient mix. If you're primarily commercial, then it's the commercial plans that will have the most influence. If it's Medicare, it'll be the Medicare value-based that'll be most influential. Or if it's Medicaid, it'll be Medicaid. But you have this point where you're crossing over and you're getting more of a balanced provider. Then the danger, of course, is they'll get involved in all the different value-based payment, and it'll become too much of a strain on them. So when I talk about this cultural conflict, it's directed at the model of care. We have a different model of care in value-based payment as relates to the primary care provider. But fee-for-service culture allows the specialist to capture the patient without any concern for the cost or the fact that they should be sent back to their primary care provider. It also creates a conflict of financial interest. By that I mean, if you know that you can generate so much money in fee-for-service, why are you going to put the time and effort into value-based if you know that by doing so, you're going to spend more money and you're going to have to take risk on the part of your practice? So this management of the financial interests of the provider and value-based arrangements, there must be evidence of an adequate return on investment. And that's one of the things that we do as an ACO, is we show them, okay, if we do this based on the patient population we have, this is what we see as return on investment. But this conflict at the model of care level plays out in terms of, I'll give you an example. During COVID, we had 60% telehealth use. After COVID, it went down to 25% because providers wanted those patients back in. Yet I really felt that telehealth expanded access to the patient and we should continue to build on it. The feeling was, no, the patient should just come to me. And so you get this effect, if you will, of where what's good in terms of value-based access doesn't work in terms of fee-for-service. So the way I look at it when I'm looking at our data is, okay, where should the budget be for primary care investment? And where is it going to come from? So I have to get the money from the reduction in hospital use and SNF, reduction in ER use, reduction even in professional specialist use. And I want to transfer those dollars into my primary care network. And that takes time to build the dollars up so that I can then invest in my primary care network, as well as in my ancillary network, home health and other services that I can use more effectively if I can incorporate them into my value-based approach. And so that's the dilemma. But even so, to improve the provider's practice, I need to know where we should put our money. So what we have found is we need to have training and professional development for providers and for their staff, invest in care coordination and care management. Digital technology is very important for connecting with our members, especially adolescents and others, but even senior citizens. IT system support, including EHR, data transfer and exchange, outreach staff, and then population health analytics, which is so important to bringing the providers along so they can see where the opportunities are to manage the population going forward. So real quick, this is providing better care through reengineering. This is how I see it. This is my vision, where my primary care providers' focus is prevention and chronic care management and self-care support. And that in the blue area is where I see negotiating with specialists on bundle payments and episode type payments. But each one of these steps requires a level of maturity on the part of my providers and level of investment. And as we move along this continuum, even though this is how I see our vision, putting the component parts together can be a challenge. So this is an example of the things that I look at and talk to my providers about. So this is a hypothetical first quarter report 2023. It's based on per member per month costs. And what I was pointing out to my provider network was that our per member per month cost was skewed towards acute care, hospitalization, SNF use, and to outpatient, which outpatient hospital is ER, outpatient specialist, etc. And the question is, if we're going to reduce costs, we need to know what the strategies are and where the costs are to begin to reduce the costs associated with these elements. And this will require us to break our population down and look at the opportunities for prevention and avoidance, early identification, and then intervention. And it's one thing to identify that a person has multiple chronic conditions and they're at risk for a hospitalization within 6 months because they've had previous hospitalizations for the following conditions. And if we do not do earlier identification of when that condition is becoming acute, whether it's a COPD condition and it's a pneumonia, etc., those costs will continue to go to the hospital. And so this is where you get into really detailing out at the practice level, where are opportunities? It's not penalizing them, it's working with them to manage these opportunities to reduce costs. And that's something that a lot of providers have never had anybody really breaking down both the model as well as where the opportunities to reduce costs. And then what we do is I determine what they're going to do, and I say, okay, I'll support you with this. If you're not able to do that, then I'll bring this into play. This is another type of report where I identify to my providers which conditions we are seeing a lot of cost associated with individual members, where we can turn it around and avoid some of these acute care costs. Now, acute care costs has two elements. It has the acre hospital costs, and then it has the post-acute care costs. You certainly can work on the post-acute care side, but where I'm looking at is I want to do the prevention side. These individuals should not have ended up in the hospital. So I look at, well, when did we last see them? 6 months ago, or not in the last year. And that's been part of the issue is we've got to use our community health workers and others to identify when a patient should be seeing their primary care provider, and then provide whatever access is necessary, whether it's telehealth, whether it's bringing them into the clinic. But to do those earlier interventions is so important to controlling costs, because it doesn't help once they're in the hospital to try to control the post-acute care costs. What we have to control is why they went to the hospital in the first place. What could we have done and when to avoid that particular acute episode? So we have to consider, in the broader view, all the different types of providers we have in our market. We have individuals and small groups, and they have one belief in value-based. Oftentimes they see it as a threat, or they see it as something they don't feel they can engage in because that's not the way they practice. And then you have the larger groups that are more aggressive, and they're getting into the more Category 3 and Category 4 value-based payment. And then you have your integrated delivery systems with anchor hospitals. They're extremely aggressive in our market. I don't know about yours. What they want out of that is market share. They want those members in their primary care network so that they know how many members they're going to have and what the potential value proposition is with that. Then you have academic medical centers, which have as their goal training. And how does this fit within the training mission of the academic medical center? Community health centers and independent practices. Well, community health centers have a broad safety net mission. And I constantly come up to conflict with talking to the providers, say, well, our mission is bigger than that. We can't just focus on these patients. I'm saying, I'm not trying to say focus on my patients. I'm saying start with my patients, then I'll invest so that you can focus on the rest of your patients. But we have to start with these patients because this is where we can get the dollars to make the rest of the investment in your practice. So some key factors of success. Number one, long-term commitment to value-based. If you haven't articulated this at the state level or commercially or certainly Medicare has, you really need to say we're committed to this long-term, because that's what providers, I hear, well, are they going to continue with this? Sure, providers can reach their tipping point. Assure a stable population of patients. This is often a challenge in Medicaid, but also in the commercial market as well. And then ensure providers have the capability to effectively care manage their patients. I'm talking about their primary care providers being able to see their population and all the things I've said about outreach and early intervention, et cetera, that they have the resources to do that. And then, of course, the analytics are so important. Timely provider level patient costs and of care data is important. Not to try to say, oh, we're going to manage them so they're not generating costs, but manage them better so that they don't need to go to the hospital. And there are less expensive ways to manage the patient. And then, of course, effective engagement. I'll harp on that, and patient activation. For my health centers, this was a big challenge. Their relationship with the patient was more transactional because they saw the patient as, well, I see this patient, then I see this patient, and their appointments were set up, and then they had 40% broken appointment rate, so they just overschedule. That's such a fee-for-service culture. What I was telling them is you need to identify these patients and make sure these patients, the high risk, the high need patients, that we've developed a clinical model of care that will reduce their use of acute care services, because now they're engaged with you and activated by you, and they see you as an important part of how they navigate the system in the future. That is still, in my case, in my network, still a continuing effort, if you will. And then, of course, setting up a preferred specialist organization is a challenge in rural communities, but it's still something that we need to do. And then I will also say continuing medical education. In my case, my providers really need to have continuing medical education about these acute care patients and about their episodes of care, because they have been focused primarily on women and children and transactional care, that they're not as comfortable in many cases with very specialized, very complex cases. And then support addressing health risk factors, health equity risk factors. That's a role that we've taken on to organize, and that includes building community resources where there are no community resources. That is a role that we feel is critical to our long-term ability to both engage our patients, but to reduce costs associated with ER visits and hospitalizations. So what are some of the pitfalls? Well, I think I've covered most of them. Too few value-based patients are assigned to you, so you really don't have the return on investment. Participating in too many different models. Some practices go out and participate in multiple models, and therein lies the problem, because those models conflict with each other in terms of requirements. Contractual requirements, do they align with your mission or not? Can you make them align with your mission, or can you make your mission broader? Unfavorable attribution, where certain providers get an unfavorable attribution, makes it more difficult if you're treating them without risk adjusting their practices. And in some cases that does happen, especially just because you're giving them quality targets doesn't mean that that population of homeless patients or patients who don't use the delivery system effectively are going to be easy to get that quality measure met. And so that's an adverse population for that quality measure. And then patient turnover is a big issue, especially if it's during the performance year or performance period. Inability for primary care providers to coordinate and manage their patient through the specialty referral and get that patient back. That's an issue. And then inconsistent data and practice level performance reports. Okay, so finally, policy considerations. The state has the opportunity to look at the covered lives in value base and to align the covered lives with a stable population that allows the provider to really manage the care of that patient over time. This is especially true in Medicaid, and you have to consider that when you're looking at the issues associated with quality performance. Number two, actuarially assign assignment minimums. Oftentimes we set minimums, but we really don't look at the population that is in that minimum number and whether it's actuarially possible to achieve the results that are necessary, especially when you get to shared savings and shared risk. To assure that there's a reasonable return on investment, if you want the providers to participate, they have to have the assurance that it's not all on them, that they have a reasonable chance for a return on investment. And then consider giving alignment between, making a policy alignment, greater policy alignment between Medicaid, Medicare, and commercial. States are in a position to do that. CMS has tried to get states to do all-payer value-based payment structures. It's really important, if you want value-based to go forward in a more organized fashion, that someone has to take a lead role in that regard. And then consistent policies on data sharing, and then a long-term commitment to value-based payment. Those are the key policy considerations that I throw out there. And now I'm going to open it up to you and your questions. So. Anybody have questions?
We'll do interim questions first and then online.
Okay.
Great. Thank you for your talk. Question about the care management, care coordination part. What exactly do you mean by that? Like, who does that? Where do they sit? What do they do? Can you talk more about what that is?
So it depends on the patient population, their acuity, their complexity of their risk factors, but we use an RN for high, what I call complex cases, who can look broadly at the person and bring information to the primary care provider as the kind of the lead around the clinical model of care. So an RN it can be used in those cases. If you're talking about a population of relatively stable children or adolescents, you can use an LVN level, a licensed vocational nurse. But personally, I think because of what we're asking them to do, which is to be the eyes and ears of the provider, to know when they need to see that patient, to do the individual care plans that are so important, that bring in all of the areas that need to be addressed, including the whole person, their cultural orientation, their what goals they have in terms of their quality of life, to then bringing that in and allowing the beneficiary to participate in that decision making. That takes somebody with discretion and knowledge. So we use RNs as much as possible.
Or based on.
Some of both in ours. The health centers that don't want to invest themselves, we do that for them, but they're always connected back to their primary care provider. They're not out there just, well, we're your care manager, go talk to your primary care provider. There is this relationship that they have with the primary care provider. And so as we do it for our health centers, we have an MOU that says, okay, you're going to make available the primary care provider. This person's part of your team, even though I'm funding it and providing it. Also, we include with the care manager is community health workers to go into, to be outreach workers and what I call problem solvers. You know, the things that healthcare doesn't solve well, community health workers can help you do that.
Hi, thanks again for your talk. So I learned a number of years ago that it takes anywhere from 5 to 7 years for a resident to unlearn the behaviors that they've learned in residency. And so, there's a big part of this of behavioral change and attitude shifts and so forth. And I'm curious your thoughts on, how early do we intervene to try to help primary care physicians learn about this versus, they're growing up in fee for service. So, and just would love your thoughts on that.
So, because of that, we're finding a lot of residents going into staff models where they really don't have to deal with all of the management of this as an individual practice. But what we have found is that in those states where the state has taken it seriously, the residency programs are starting to provide experiences to their residents. And the one of the things about value-based is it's really about the opportunity to manage a caseload of patients to a specific set of targets over a particular period of time. And I was looking at the residency training requirements, and there are definitely components of that. Now, how well they're organized, how much support, are there care managers that the residents work with so they get used to working with care managers and how they think? Are there, do they work with community workers? What are the sites of care that they that they have their opportunity to participate in managing patients with complex multiple chronic conditions, or just patients who need to have a holistic approach. So I'm hopeful that the residency training programs have seen the light, Myra, and are beginning to address this issue as they come out. Because you're right, retraining the residents is not the most effective way to do this. But I am impressed with what you're doing here in Colorado, and even there is a lot of talk in Arizona about changing the residency training program to give them more experience in this area.
Hi, thanks again. You mentioned a few times the need for stability amongst the population, and Colorado, like many states, is dealing with the impacts of the end of the public health emergency with regards to the Medicaid population, as well as other policy efforts to allow for continuous enrollment and coverage. So there are a lot of shifts with that population. I'm curious how you see that impacting value-based care and how to mitigate some of those consequences.
Because you're assigning the patient to a primary care provider, what I would like to see is changed in the state's assignment process is if you're participating in a value-based payment, they will give you guarantee of eligibility for a year or whatever period of time, as long as you're in the value-based payment. That way, now the patient or the beneficiary begins to know, oh, what's this value-based payment, and what does that mean for me in this new relationship we're trying to establish, and understanding that, and I there's legal issues, et cetera, but if we can some way connect that beneficiary's continuation in the Medicaid program with being value-based, that would really help us.
Thank you. Hi there. Yeah, thank you again for your speech. So I guess one of my concerns is that there seems to be an incentive to select specific populations with this model, and I was just wondering if you correct that perspective and help explain how an individual is determined to be within this value-based system, and how bias isn't included in that process.
It's a very good question, and I found it payer-specific as to how biased they are about who gets assigned. In Medicaid, you get assigned a population of patients who have at least had the predominant number of visits with your primary care. In our Medicaid program, we get assigned patients who have never even seen our clinics. So is that a bias? Yes, and it does create significant challenges on the part of my providers to engage patients who didn't choose them, or they may even be going to other primary care providers. The state has the policy authority to recognize that and make adjustments. On the commercial side, they do the same thing, and I think that's why I would like the state and the commercial market to get together, agree on alignment on how they're going to move forward with this, and then bring the federal government along. Because with CMMI, there's a real opportunity for state-specific solutions. It's just that a lot of states don't come forward with a all-payer solution. They come forward with a Medicaid solution, or the payer solutions are done by under the insurance department or whatever. And it would be really great if the state, and my state in particular, would come together with the other payers and align the way that they do their value-based maturing process, because we're not where we need to be. But if we're going to go in different directions, we're not going to end up where we want to end up.
We're going to switch over to our online questions now. There are quite a few, so lots of thanks for being here today. So the first one is, specialists drive the cost in American healthcare, yet PCPs are the focus of accountability in most of these programs. Specialists are rarely a regular part of the conversations, so how can the value-based payment programs be adjusted to ensure more accountability of specialists? They had a for example that I can go into. So there's a procedure that they mentioned that reduces infection but increases brief experience of patient pain and requires an OR rather than an office setting. And surgeons and PCPs are not agreeing on the appropriate approach. So how do they assign a value-based proposition to situations like that?
Well, you hit the nail on the head. They need to be mutually accountable for that episode of care. Now, specialists are going to focus on the types of episodes that they're trained as a specialist to handle. So you have to, with each type of specialist, establish the kind of accountable episodes. And that's where the ACO or some organization, in terms of bringing them in as part of the value-based process, either they participate in the shared savings or whatever, to get them to integrate with your primary care provider. It has been proven over and over again, integrated care models for complex patients work the best, including behavioral health, bringing the behavioral health specialists into it, recovery specialists. When you work together and you're engaging the patient, you have much better outcomes. The problem is that our system of fee-for-service has broken down everybody into their functional silos. Specialists get their money, PCPs get their money, the hospitals get their money. This is trying to integrate with the dollars so that it drives the system to better integrated care. And I do understand that not every primary care provider has relationships with their specialists that their patients go to. That's where an ACO or an entity over the entire system needs to reach out and bring preferred specialists, if you will, together. The one thing you have going for you in doing that is you get the Stark safe harbor. So you don't have a Stark problem if you bring specialists in and if you create a preferred referral network of specialists who are willing to better integrate with your primary care providers.
Thank you. Do you have some specific recommendations for professional development opportunities for practices and staff, like best care management training, best professional society or best professional society or other group for symposiums, conferences, etc.?
So one is giving the primary care provider practice time. The other one is to support them to participate in whether it's a society that's putting on professional training, or whether we do that as an ACO, or which is possible that we'll do some of our own professional training. The issue is you have to assess where your primary care practices are, and then build a training regimen that gets them from where they feel they are to where they feel they need to be if they're going to manage these patients. And that you use every resource you can find. And I'm constantly looking for resources that I think our practices would find useful if they went and did the continuing education. There's also, in the case of community health centers, the leadership group also has to be brought along with this as well. And so we do a lot of e-learning. We do a lot of podcasts, just-in-time information to get out there to our practices. But we still have a long way to go. And even academic medical centers can help in this area. Myra.
That was a nice subtle comment from Myra. So our next question that we have online is, it seems flawed to have outcomes defined solely by payers, not collaboratively with providers accountable for delivering them. Also, what about outcomes with input from patients as well?
Well, I'll take the last question first. Yes, I agree. The patient's view of healthcare is different than ours. So what we see as a good episode, they want to know how they want to tell you how they felt, how well they were communicated with, where they respected, etc. So it is a different level of information that we get. that we have to respond to and not just ignore. Communication has been a big issue in many practices. Practices think they communicate, but you talk to the patients, they haven't heard what the practice is saying. So you can't just expect the doctor to be the one who's constantly educating it. It's the nursing staff. It's the community health worker. You follow up. You use e-learning. We're looking at e-learning for our patients as well. And there's a lot of different technologies you can use now to push out and reinforce what is learned in the clinic. But so that is one issue. The second issue, collaboration. Yes. However, you've got to have leverage. And you won't have leverage as individual small group practices or even large group practice. You've got to be large enough that the payers will pay attention to you. It would be great if the state would be the convener and to allow that dialogue to occur. But if not, you've got to have leverage whether you pull other ACOs or other networks together and say, let's go negotiate a better value-based payment for our providers. I will say as a payer, payers listen to that. They may push back, but you bring data, they will listen to it.
With your background in public health, can you comment on policy alignment in this regard, as poor public health creates a glass ceiling for us?
Public health. My heart hurts. The problem that happened 4 or 5 years ago is public health started to become political and lost its trust factor with people. People began polarized around the term public health, etc. Public health has a lot of the data, the information, and the opportunity to guide where there's opportunity to improve on the population health. Plus, it can wrap around its public health strategies, especially in communities. We have high-risk communities that generate healthcare problems, and we need public health to prioritize those healthcare problems. But they've been so underfunded that they've kind of pulled back from being able to do that because, well, if we do it in this community, we have to do it for everybody. And unfortunately, that's an attitude we've heard. I think it's up to states to reassess the role that their public health organization it plays in helping the state to control costs and improve the overall health of its population. If it doesn't turn to public health, who's it going to turn to? And if it doesn't realize that public health has been underfunded, at least in our state, it's not going to work. They can't do it on after you've cut the budget back, politically narrowed their focus. And so my hope is that state legislators will begin to realize that was a very short-sighted approach to public health. I don't know how it is here in Colorado, but that's what I see in our state and other states.
Thank you so much. For context, we have about 13 minutes left and we have 4 more questions online. So I'm going to just go ahead and say we'll ask those and then we'll be done in the room. So do you have any experience with physician practices that were at or above the 35% threshold level of patients in value-based that went back to fee-for-service? If yes, why did they do so?
The only ones that I'm aware of, it was because the organization that they had been working with failed to achieve the results that they felt they needed. It also had a lot to do with their payer relationships. If you have a practice that is committed to value-based and you can stabilize their value-based model so they can see the return on investment. I've never seen a practice go back from that. Where I've seen practices go back is where you ask me to do all this work and I have seen nothing in return on investment, or you change the rules on me and now you've made it more difficult for me to achieve the results that I need to achieve. And that, again, is specific to either payers or even under certain situations, state Medicaid programs that have kind of undermined their own value-based programs. So that's why I say there has to be a long-term commitment, and there needs to be collaborative leadership by payers, by the private payers, by the state. And as I said, I think the federal government will come along with you if you can show that leadership.
Thank you. Next question is, do you use integrated behavioral health service delivery models such as the collaborative care model as part of the value-based payments? Any focus on identifying high-risk medical patients with psychiatric comorbidities?
The answer is yes. It's really important to do that. However, one of the issues in our state is that if you're seriously mentally ill, you can choose which behavioral health organization you go to. So we have a number of behavioral health organizations that are not aligned to my health centers. And it's getting them to align so that we can integrate care about the members that they're responsible for that are outside of our primary care network. That's been a challenge. This is a place where state policy regarding freedom of choice goes against the ability to then achieve the results that the state wants to achieve, which is better integration of behavioral health. And one thing that I felt very strongly about is why not then give those behavioral health organizations an incentive to participate with us, because there's no incentive right now as a behavioral health organization. It's all on the primary care provider, and if we have our own integrated behavioral health units, which we do, but the member can choose to go to a different behavioral health specialist, and that just creates a problem for us to coordinate care when they say, well, we have our own set of issues. So I need the state's backing to say that they want this to happen, that they want to have better integration on value-based payment.
The next question has an additional thank you for being here today. And then with the focus on risk adjustment, post-acute strategy, avoidable readmissions, etc., I worry that we will never invest in and get to the quote-unquote template of the future, where physicians are leading an effective team to manage populations and extricate themselves from FFS visits. Waiting for payments to support these teams as the bar keeps rising seems hopeless. How do we shift to this model?
Well, you have to have a driver, and you have to have support. In the state, in your state, you do have support with your innovation center and your practice transformation program. I'm a real supporter of practice transformation programs and continuing the effort to continuing to move practices forward. But there is a danger here that in many cases, and I can't say everybody's Colorado, that physician practices will feel like, okay, I just got set up because even though I'm trying to achieve this, I can't get to the next level because you're constantly focused on these short-term financial gains, and you're not investing in any of my long-term model change so that I can be what you want me to be. And that's why you have to have size. You have to have enough members in your population, and you have to return the money, and not 90% of our money goes back to our health centers. So it allows them to make investments and anticipate the return on investment, which then allows them to put that money, in the programs that we're talking about. But that takes time. It's not a one-year thing. It's a multiple-year thing. So you got to have leadership. It's not serendipitous. It happens because leadership makes it happen, and that's the best advice I can give you.
Thank you so much. This is our last question, and I think it's a great way to end, given that we are family medicine. So how is this model communicated to the patients to make them familiar with the difference between the different approaches? Do patients have additional appointment time with providers, or is it similar to what happens in fee-for-service? And then what kinds of feedback have the value-based care patients given to providers who are utilizing it?
So because we are restricted on what we can say to beneficiaries about the provider's participation in the model, what we try to do is say, these are the services you have available to you. Care manager, that's a personal care manager. We have community workers that are going to be helping you if you need transportation. So we're telling them all the things that they will get because that we're connected to their primary care provider. And what I've told my staff is we always say, it's because your primary care provider wants these things for you to help you with your chronic condition or help you get access to care more rapidly and to do earlier intervention. This is why these are services that are available to you. So we never market value-based. We just market what we're able to do because of value-based. Now, is that the right way to go? That's the way we're doing it. And the rest of that question was?
What kinds of feedback have the patients provided?
So it's early. There is some skepticism on the part of patients that why now? Why is this so? Why do I have a care manager now? I've been going to specialists and doing whatever. So there is this period of building trust, and we're in the period of building trust. During that time, we want to get feedback from our patients, but understanding why they have foregone seeing their primary care provider is one patient is different than the other. It may be because they had a bad experience, or they had to wait a long time, or the provider said, well, I don't know anything about your problem. You have to go back to your specialist. There's a lot of reasons why we've seen this disconnect. So we're pulling it back together again, and the jury's still out. So hopefully in a year, I'll be able to tell you more about what works and what doesn't work.
All right. Thank you very much, Tony, for coming and sharing your experience with us. And I want to thank you all for taking time out of your days, those of you here in person and those of you online. And please give us some feedback. We take it very seriously on our lectures. I think Liz, for the online folks, she's putting a QR code in the chat. And for the folks in the room, we have the QR code on the table to give us some feedback. And so once again, thank you very much. And thank you, Tony.
Thank you.
You've learned a lot over the years. A lot to share.
Well, thank you.
Yeah.